I'm really glad to have my panelists here. So I think what we're going to do is we're going to have a conversation with some acknowledgments here. So some of the pictures in here were from the SITC's immunotherapy toxicity management slide set that they had given me and I used in my previous slides. So I'll just make the introduction. So a lot of us have been using immunotherapy for now more than 5 years, 10 years from melanoma doctors. And we kind of have seen an evolution of how we see the toxicity evolve. So the immune checkpoint inhibitors have a different way of mechanism of action. So what that means is that we have a different side effects we see compared to chemotherapy. So the therapeutic index, the difference between the toxicity and the benefit is different for the two. And what we see is the dose-limiting toxicities can evolve over time. They don't necessarily have to happen right when we start the treatments. And the time of treatment effect is also longer, which we're seeing in the conversation we have had with Dr. Heinrichs and other presenters today. So this is a slide sort of talking about when we see these therapy side effects. So as you can sort of see, the skin side effects, very, very common, happens in about 33% of patients in this particular study. Has very large variation when you can actually start seeing it. It could be as early as the first week, but as late as a year from start of therapy. We also see GI side effects. Median time is about 7 weeks. Hepatic dysfunction, also at about 7 to 8 weeks. Pulmonary, endocrine, and then renal. There are other side effects that do happen that I will not be covering here. There are some important ones like myocarditis that I will not be covering here. I'm going to talk about the more common ones today. So just as a way of making sure we are all on the same page, I just want to re-familiarize everyone to the common toxicity criteria for adverse events. This is published by the NCI. This is updated now in the 5th section. There is one specifically immunotherapy specifically. But there are grades. Grade 1 is mild asymptomatic to grade 5, which is death from the adverse events. Typically, grade 3 is sort of the threshold we report many or differentiate in our publications because they're severe or medically significant. So when you think about interventions, we want to make sure we grade the side effect first so we have the right interventions. So here is sort of a different picture looking at the immunotherapy-related adverse events with checkpoint inhibitors. You can see there's like dermatitis from the cutaneous perspective. It could be different variations of dermatitis we'll go over in a bit. GI side effects could be something as colitis, diarrhea, hepatitis, gastritis, musculoskeletal with arthritis, myositis, pneumonitis from pulmonary, and endocrine dysfunctions. And we're going to focus on the one in the green, as they are the more common ones that we will encounter, and so we'll sort of discuss that together. So what I'm going to do is I'm going to start with cases. So I'm going to present the case, and I'm going to ask my colleagues to sort of educate us on how they would manage it. And so we're going to try to make this a bit interactive. So this is a 65-year-old gentleman who presented with metastatic melanoma in 2021 and had lung and liver lesions. Treated with ipilimumab and nivolumab, which started a month later, and has now called the office to report a new rash. So the question, because when you see the rash for the first time, patient calls you, how would you manage this? What's the first thing that you need to do? Or in other cases, when you have a small office, how do you train your care providers and your nurse or triage person who's going to answer the phone? What to do is the question. So my question to you, I think this is for Dr. Norell. So if this patient called, what's the next step?
Succinctly, first we would want to rule out any new changes in medications. It could be a drug tox, a viral, something viral, and then we drill down to, after an evaluation, we would drill down to what percentage of the body is affected, what does it look like, and look at where they are in their therapeutic plan, either certainly grade it based on how pervasive it is, and then make a decision from there following the ESMO guidelines.
So we ask this person to come in, we look at it, and sometimes we might need to get some help. So I have a slide here, and Jackie, if you just sort of wouldn't mind sort of walking us through this in terms of what some of the different rashes might be, what it means from terms of pathological perspective, because at some point in time, we got to be able to manage it. We got to decide what to do about it. So Jackie, if you could help us with that, please.
Sure. So you have a presentation here with a group of rashes provoked by therapeutic treatments with Pembro, Nivo, Atezo, and rashes ranging from first one is grade 3, second is grade 2, third is grade 1, last 3 are grade 1 and grade 3. So the histopathology is interesting because where you might be prompted to prescribe a topical, there are instances dependent on grade where an effect to patient, so you may have a grade that is not severe and the patient is, I can't sleep at night, my skin is itchy all the time. So you would treat, again, based on ESMO guidelines, and that might be a combination of medications to arrest pruritic symptoms and then possibly prednisone.
So Jackie, because prednisone is an interesting thing, right? So we'll talk about that a lot, the different steroids. So we will use topical steroids when it's sort of lower grade. When do you think there's a need to do oral steroids, and any guidance of how do we sort of manage the future doses of immune checkpoint therapies?
Right. So again, referring to the guidelines, they're very clear about BSA coverage and supportive care. So grade 2, you could potentially proceed with treatment. So there's a level of flexibility in terms of management, but clearly, of course, all grade 3 scenarios, you're holding treatment.
So again, the hope is that we would treat this with topical because we identify early, and we would sort of intervene with the topical steroid, and we will see it reverse, and then we can potentially continue therapies. And if necessary, we may need to oral therapies, and as we sort of have talked about, if you can do prednisone of 10 milligrams or less, you can potentially continue the immune checkpoint therapies. The next person, same format. We sort of have a patient is a 69-year-old with metastatic kidney cancer. This is actually a patient that I saw in the hospital for the first time. So he was diagnosed at outside hospital a few months before I met him with brain and bone mets, and had prior therapies because of brain mets. He had a gamma knife surgery, and he was treated with steroids. That started around May. And then it was started a month later with axitinib and pembrolizumab. And talking to his primary oncologist, it looked like he may have been on steroids on and off in between as well. So he first presented to outside hospital with dizziness and was found to have, on history taking, that he had some severe diarrhea, about 10 times a day, liquid bowel movement in the prior few weeks, which he had not reported. He was evaluated by the gastroenterologist at that point in time and put on oral steroids. And that was tapered over 4 weeks. And then was re-challenged with pembrolizumab and presented to our hospital again with lethargy. At this point in time, he was found to be an acute kidney injury with granulin 5.0 and metabolic acidosis. So again, you're the oncologist on service, you get called. So Dr. Balan, if you won't mind, so what sort of goes through when you get that call at 10 at night from your colleagues in the emergency room?
The first question is what's behind patient symptoms, and as Jacqueline mentioned implicitly, that immunotherapy-induced diarrhea, colitis, is a differential of exclusion. So you need to make sure the patient doesn't have C. diff or other comorbidities. And that's one of the challenges, how to establish the diagnosis. I think we sometimes underestimate the role of imaging studies and of labs. It's useful to identify if there's an inflammation behind it, and sending lactoferrin, for example, can indicate that there's inflammation. If there is a suspicion that this is a true immunotherapy-induced colitis, then imaging studies help too, like a colonoscopy in this case. you have some good images here.
Yeah. So again, this is just for attribution. This was from the SITC slide set. There are several different images that are talking about different kind of inflammation that you might see on a colonoscopy. Dr. Balan, right, so first time here, diarrhea, 10 bowel movements a day, that's at least grade 2, maybe grade 3, depending what the baseline was. Would you recommend getting colonoscopy during the first hospital admission versus sort of trying to manage this with prednisone?
I think my threshold is pretty low, relating this to the immunotherapy. So you can send the lactoferrin, and yes, I would do the colonoscopy. There's actually emerging data suggesting that the earlier you do a colonoscopy, you can actually decrease the length of the episode, and you help the patient recuperate. About lactoferrin, as the name says, it's related to milk. So in infants, you don't send this test because it tends to come falsely positive. If a patient has a glass of milk, though, it does not interfere with the results. Okay. As I was thinking about this case, I remembered my parents telling me a story. I was 4 years old and watching on TV a cow mother feeding a calf, and I was like, "You." And my father said, No, your mother did the same with you. And after a pregnant pause, I said, "Daddy," that's what my father said. I asked, "Was my mother a cow?" So no, it doesn't. Actually, the way the test for lactoferrin is engineered, it does not give false positives with milk.
And it's sort of, so again, in case of severe, the colitis, and it does not respond or does not improve with steroids, we might need to escalate immunosuppression with infliximab. And again, in that case, I would probably making sure that you have a good GI colleague working with you, and getting some pre-therapy testing, like making sure the TB and other important immunosuppressant testing has been done.
And this is one of our challenges in community hospitals. As we use more and more immunotherapy, we need to work hand in hand with our GI specialists who might not be up to date with the information regarding this.
And actually, that goes more than that. You probably need to develop a network, right? So a dermatologist that you can send someone to right away who will see the person within a day or two, right? There's no point in having patients suffer too much longer before we start the intervention. Getting a biopsy potentially may be helpful. So having that network around you is tremendously helpful. The next case. So this is a person that was, I think that Dr. Pachela had seen, a patient with melanoma who was originally diagnosed in 2010 with a localized disease and resected and hopefully cured. Unfortunately, several years later has had multiple resections for in-transit melanoma, and had recommendation for adjuvant nivolumab as part of standard of care. And what we noted was this trend. So as I sort of said, December was the first dose, and you can sort of see the thyroid TSH on the top every month, with every infusion. And then you have a T3 and T4. So Laura, I mean, first stop is July. You start noticing the TSH has gone down, thyroid, the hormones are sort of going up. You see this. What goes through your mind?
It just starts to signal, maybe this thyroid is inflamed. Maybe it is caused by the PD-1. And at that time, we explained to the patient, we're going to watch this lab very closely. We're not going to take any action right now. But I don't want you to be surprised if we need to start some kind of thyroid replacement in the next couple of months. And also, the other interesting thing there is you can see how her weight dipped in the summer. And she thought, I'm doing great, I feel good, I have high energy, I'm losing weight, this is wonderful. And I said, oh, okay, we'll see how you're doing in a couple of months. Okay.
That's right. And so it's just interesting. One of my colleagues, my office mate from a decade ago, she would say, it's really hard for us adults to lose weight. If you see your patient lose weight, look for other things. So that's a good reminder. So she clearly did not have a specific symptom that she reported. She was actually glad to see the weight loss. Any other things that you sort of worry about developing over the next few days, next few weeks, next few months?
We just continued to watch her. When she came back to the office actually in September, when her TSH was very high, her T3, T4 very low, she actually did have some symptoms of mixed edema. So that was interesting to see. And by that point, she was regaining weight again. I always think back to this picture when I think about hypothyroidism. It was from my undergraduate degree in nursing. And she had the clinical picture of hypothyroidism, and it just like jumped off the textbook page to me. So it was just kind of interesting to see that. We did start levothyroxine. That was on a Friday. I called her the next Monday, and she said she was already starting to feel better. And this month, we repeated the labs. Her TSH was about 4. So
Wow.
she was feeling better, too.
So clearly, this was hypothyroid that sort of evolved. The first indication when you saw the hyperthyroidism. When you see the hyper, do you do anything about it?
No. We just
Okay.
watch it because it's almost a clear sign that the thyroid is going to kind of burn itself out. We just watch closely the next month, and almost always it's like clockwork. You can predict that it's going to be hypothyroidism by the next month.
And sort of speaking of collaborating with your clinical colleagues, how often do you sort of have to send it to endocrinology, or when do you send it to endocrinology?
Yeah, we send endocrinology when it's difficult to control the hypothyroidism. That honestly doesn't happen too often, more seen in other disorders of endocrine, but we have had to send a few patients to the endocrinology team.
Okay, that's good. So next, we have a total of 6 cases. The next one is a person that I think Jackie had seen, a 72-year-old person with, again, history of melanoma. And melanoma is sort of a lot of cases because they used a lot more immunotherapy and have been losing much longer than most others, including myself, doing GU medical oncology. So again, melanoma and left abdominal wall, and recommended ipi/nivo as standard of care. And so patient sort of has called the office with, again, a rash after the 3rd dose, but also has, on further questioning, weakness and confusion. And so we sort of talk a bit more, and then we get the history that there's some poor appetite, they're vomiting, they have headaches. And so they are sort of sent to the emergency room. In the emergency room, they're described as being alert, able to follow some simple commands, but not great on the mini mental state examination, and sort of non-focal examination. And the blood work in the emergency room shows hypoglycemia, sugar of 60, and also hyponatremia, 129. So at that point in time, Dr. Norell, you're called because you're covering that day for the melanoma team because they're out at a conference. So what goes through your mind at that point in time?
Looking at where they are in their therapy, so what in the clinical setting we've seen at that 3rd dose of IPI, things happen, a lot of activity between 3 and 4, and then at the higher doses. And so scenario similar, that we would see the patient, this patient scenario, the patient's in the ED, in outpatient setting, it would be an evaluation in the clinic, and with a symptom report, and then definitely an MRI of the brain, and then beginning steroids. Other variations of these scenarios we've seen, male patients present with 3 in the morning night sweats, and mood changes, and typically 3 in the afternoon and 3 in the morning consistently.
Interesting. So what were you thinking? I don't think we know what the diagnosis is here, though. So what was your thought process? So what's the workup that you might sort of want to do? What's the diagnosis, or what are we thinking of?
Hypophysitis. Sorry. Hypophysitis.
So again, this is a central process, and here's sort of image of sort of seeing the pituitary stalk and the swelling there. So what we see here is hypoglycemia, hyponatremia, but also low cortisol level, and the TSH and ACTH. So this is a bit more challenging, as Dr. Pachal was mentioning. So thyroid we can sort of manage. Sometimes you need a bit more help with the hypopituitarism. So how do you sort of typically manage this?
With the steroids, the thyroid would level off.
Yeah.
And then, but I haven't seen anyone where they were long-term not prescribed the steroids. They continued the steroids, but I will say, with what appears to be a durable response. This is not scientific data, just observational, but durable response.
So again, this person, as Dr. Pichal mentioned, was treated with IV steroids at this point in time for 5 days and then transitioned to an oral steroid regimen with an improvement in symptoms. Again, we want to sort of see patients getting better before we sort of get them out of the hospital. So the medication improved back to baseline within the first week. As Dr. Norell mentioned, we will probably want to make sure that this patient probably needs endocrinology follow-up, needs replacement of their steroids potentially, both the corticosteroids and mineralocorticoids, not just sort of prednisone. So this is something that's an important, requires multidisciplinary care and management. So the next case, this is a younger gentleman with melanoma who was initially diagnosed in 2013 and treated with surgery and had high-dose interferon, and then several years later had pembrolizumab on study with a complete remission. Then they developed brain mets that were treated with the local therapies in September 2020, and then started with Ipi and Nivo in October 2020. So now I sort of have some labs. So here are the liver function panel, and I just focused on the bilirubin, AST, ALT, and alk-Phos. So after the cycle 3, they come in for cycle 4. They had the labs done the day before, and this is what we see. So Allison, you're recovering APN today. What goes through your mind right now?
Well, I'm going to ask if there are any other medications, new medications, Tylenol, maybe alcohol use. If it's been a while since they had imaging, I might want to rule out Mets or fatty liver.
Yeah, so this is an important thing, right? Because it's in a melanoma, it can do just very aggressive, so we want to make sure it's not the disease. So the CAT scan was fine. It's really not any, they haven't had any alcohol or Tylenol, intake in the past several weeks, past several months. So those are not the likely things. So this really sort of seems like it's now a drug-related. So how would you grade this, or what was the grade of this toxicity?
Is this a grade 3? 3 to 4?
Yeah, this is more than 10 times the normal. So this is pretty high grade. So here we have sort of some guidelines from SITC. So again, how would you sort of manage this person? How would you sort of do their next steps?
Obviously, we're holding therapy and steroids 1 to 2 milligrams per kilogram with frequent rechecks of the liver functions.
So in this case, though not, so this is sort of what happened with this person. Give him some steroids, and within a week, you saw improvement. What is not here, and I'm going to sort of just as an add-on, I'll sort of talk about this and go back the slide before. In this patient, we actually saw an improvement initially, but a month later, we saw the LFTs going up again. And you might see this occasionally. And what you need to do at that point in time is actually add something more to it. So again, and it says here in the bottom, if LFTs don't improve or recur after a taper, you may need to administer an azathioprine or mycophenolate. And so in this case, they did receive that. And the patient, LFTs are actually pretty much controlled and sort of doing well after all this time. See one more case. So this 65-year-old gentleman presents with dizziness and a fall and had diagnosed brain metastases and a lung mass, so it's lung cancer. This is actually a case from 2015, my patient. And he had gamma knife surgery for local disease, and then received standard of care pemetrexed and carbo and bevacizumab. That was a standard of care back then for about 4 cycles, and developed weight loss and poor taste. He was diagnosed with actually having adrenal insufficiency. He was admitted to the hospital, and then given pembrolizumab in October 2017. A routine scan at 3 or 6 months is completely asymptomatic, but this is what we see at 9 months. So you see on the left side, January 2018, and then April 2018. So Dr. Berlan, right, patient is asymptomatic. So you think that clinically therapy is working, but you see the CAT scan like this. So again, so what's your differential? What are you thinking as a possible etiology for this?
The differential diagnosis is vast. It can be a progression of disease. It can be an infection. It can be the immunotherapy-related pneumonitis. Of all the immunotherapy-related adverse reactions, that's the one I fear the most. Why? Because It's a question of time. The patient sometimes can fall off the cliff and become very symptomatic very quickly. There's nothing quantifiable like with in the case of a hepatitis. And again, your level of suspicion needs to be high.
Yeah. So again, this is the question: is it an infection? Is it pneumonitis, or is it cancer? And I think that in terms of management, this is sort of my patient. So I actually did not do a biopsy. I actually ended up sort of doing a very close, because he was asymptomatic, very close time frame, like maybe 4-week CAT scan. So when do you initiate steroids for these patients?
If you put the patient on antibiotics and the patient did not improve and there's no indication of anything else, I think it's reasonable to start antibiotics, steroids, and the sooner the better.
Yeah. And so what do you expect in terms of sort of resolution, or do you expect in terms of resolution and time frame or anything like that?
It takes time with steroids to see a resolution on the scan.
So again, this is my patient. I can give you follow-up. So I did not start pembrolizumab again. I should have held it. I just sort of watched him over the 3-month period. I had just moved to Rutgers at that point in time, and I had discussed this case in tumor board with my pulmonary colleagues, and there was a live debate about was this disease or not. I ended up not doing any a biopsy, and just sort of watched him. And now it's 3 years later, and he hasn't had any single systemic therapy, and there's no evidence of disease. So that's actually one of the other things that many times we see this when patients who actually have the toxicity may actually have longer benefits too. Mm-hmm. So one thing that I wanted to make sure I end this talk with is one of my requests from one of my panel members, which was one thing we need to do at a baseline is to really do a thorough review system and a good exam and labs and exams. Because you will have this question, what is it, that's going to come up insidiously. It's not going to be sort of like, patient's going to report it. They may never report it right away because they will just say it's nothing. So it's really important to just have a good and thorough evaluation as a baseline and education of patients to make sure they report any new symptoms. Patients don't like to tell their oncologist all the things that are bothering them because they think it's going to impact their care. Because we want to hold the treatment or stop the treatment, but we need to advocate to make sure the patients report even the smallest things. And again, as you sort of pointed out, be on the lookout for the small things that may be generalized symptoms. They may actually harbinger a bigger problem that's happening. And we really need to make sure early and judicious use of steroids and re-challenge in selected cases. So that's our thought process. I welcome any questions. We have about a minute or so. Brian.